Thank you, Jeff. And I'm humbled being on the podium with some real modelers here today. So I'm actually going to play it safe and focus primarily on the cost and cost effectiveness aspects of treatment, both in terms of treatment as prevention, but also more broadly, hit on some of the modeling impact, but to do that in the context of understanding it in the context of the resource constraints. I have to admit, last night I was facing a perfect combination of sleep deficit, shift of time zones, and wine at dinner. And so I prudently didn't comment during the dinner sessions or ask questions, but I was interested in how we morphed last night quickly into discussions of cost effectiveness, resource constraints, resource allocation questions. And so I think this is a chance to start directing, seeing what the evidence is out there. I'm going to do a lot of this from the PEPFAR perspective in developing country settings, but again, this Ambassador Gooseby showed this slide yesterday, one comparable showing the scale up of PEPFAR direct patients over time. At the same time, the flattening of resources allocated to treatment within PEPFAR, which has created this perfect storm of a rapidly expanding program at the same time of flattened resources. Adding to that perfect storm were the findings of 052. So we have not only growing program, flattened resources, but we also have incredible opportunity. So what that did was lead to a policy analysis, policy review at OGAC, in which we were pulled in as well as others, the Scientific Advisory Board being the key component in this, to basically look at what are the issues in terms of the possibilities programmatically, epidemiologically, medically, and in terms of the resources. So I just want to sort of talk about how some of that thinking went into it and review the evidence. So firstly, on the cost of HIV treatment. Again, the blue line represents the scale up of treatment over PEPFAR. The green line's the good news. This is the PEPFAR, using one of the measures we use to look at average treatment cost, average unit cost over time, this is the cost of PEPFAR of delivering treatment from nearly $1,100, $1,059 in 2005 to $335 in 2011, as was announced by Secretary Clinton. So that's the good news, and what's going on behind there? So there's issues of economies of scale, efficiencies, and then greater contribution by other sources. And I think it's important to call those out just quickly. So in terms of the economies of scale, this represents a lot of early initial investments in capacity, in systems, in training, in developing the infrastructure to actually deliver clinical-based services. It also reflects then the growing efficiency of providers and being able to handle more and more patients within a given setting, better drug procurement and supply chain systems, more efficient management of those systems. And then finally, and I think very importantly, the line is being driven down by the fact that this is the PEPFAR cost. And right now we're seeing, especially in our upper middle income settings, South Africa notably, increasing national contributions driving the scale up. And so that's actually behind this as well. So this is just pulling out, we've been doing costing work since 2006. This just demonstrated the empirical data showing that unit costs drop quite quickly as the site's initiated and is established over 2 to 3 years. We have another paper in review right now which looks at basically breaking this out on a regression analysis. What are the effects of site maturity, patient load, price level? All of these are significant and independent predictors of per patient cost. So site maturity, the cost dropped 43% over the first year. Again, we're spreading fixed costs. We're establishing the capacity, and the programs are growing and getting more efficient. 25% drop in subsequent years. Patient load is significantly correlated with, negatively correlated with patient costs. Price level, which would map to the cost of internal resources such as labor, infrastructure, and the like, increases 22% for each doubling of GDP per capita. Also, significant independent predictors are frequency of clinical monitoring, frequency of laboratory monitoring, and clinician-patient ratios, which again, I think something to start thinking about is what are the trade-offs we can start making in terms of getting access to more people given the resource constraints we're facing. Again, this is just pulling out the distribution of cost by lower income, which in PEPFAREs is basically the low and low middle income settings, moderate income being the upper middle income settings. And what it shows is the differential cost, the 638 in lower income settings, the 1017 in moderate income settings for the full cost of providing treatment in the programs, but then also the differential PEPFAR contribution towards those. So that while the cost is higher in the upper middle income settings, the moderate income is deemed here, the PEPFAR contribution towards those costs is actually smaller in a proportionally and absolute terms. Let's turn to cost effectiveness. One of the things we've been doing for a number of years, building on the empirical work of collecting site-level cost data and triangulating it with other approaches, including more routine data collection, financial data collection systems, has been to do this in order to project resource needs with program scale-up. More recently, we've been getting questions, and this was in large part, or accelerated, I should say, with the findings of 052, to start talking about what are those benefits of treatment beyond the patient. Increasingly, we're being called to speak to the benefits in real concrete terms. So essentially, when we're building budgets, to be able to respond to what do our decision makers, what do our legislators, what are we buying with the dollars, with the public resources, and how can we account for those? So what we did was to build out this cost projection model to estimate the health impact from treatment, both in terms of the direct benefit to treatment patients, HIV attributable deaths averted, direct life years saved, the averted medical costs that are associated with those, but also the indirect benefits to others, averted secondary infections, sexual infections, now it crossed into Brian and Christoph's work, averted vertical infections for women who become pregnant while already on treatment for their own health, averted orphanhood, and indirect life years saved, and the cost associated with this. Again, I think what was interesting is a shift over time where we went to once treatment was taken as a global good, to when we faced the greatest global financial crisis since the 1930s, there was a shift again to once again justify why we're spending money providing treatment in developing country settings. So we found this actually being a valuable tool to be able to speak to what the value is. So basically it looks at the patient population and cost estimates that are part of our cost projection model and estimates the broader health benefits. I should note the counterfactual here is no program or program of different scale. This was really designed for to speak to policymakers, to provide the Office of Global AIDS Coordinator a simple measure that they could provide queries. But let me stop here. I still have been facing two of my three factors in my combination last night. There's a focus on being able to talk about a program of this size, a budget of this size, what can you deliver? And so there's a need as part of the budgetary process to be able to speak to this in real concrete terms. So this is, you heard Ambassador Gooseby talk to some of these metrics last night. So we were able to estimate for every 1,000 patient years of treatment, this is in 1 year's time. This is not a dynamic model. It's basically saying, because the program exists this year, it buys these outcomes. What does that mean on a global basis when you have 3.9 million people at the end of the year that you're supporting, which led to a predicted number of patient years of treatment being provided? And then what are the averted costs? And the reason I call out here, I think we're going to have ongoing discussion during these few days about what are the preventive benefits of treatment, and therefore what are the averted costs associated with those. But I do want to point out here, those costs are represented by the green, which is about 1/3 of the averted costs that are estimated. The largest portion of costs averted are actually averted orphan care. So we should also think about treatment's benefits in terms of averting orphanhood and averting those long-term costs to society, as well as averting medical costs and the averted vertical transmissions. I wanted to point out some other work, that of Steve Reshen and colleagues, in terms of looking at treatment's returns, the cost effectiveness from a different perspective, focusing on labor productivity, averted orphan care, deferred medical treatment for OIs, and end-of-life care. So this study was done prior to consideration of the 052 findings. And here the treatment's benefits will substantially offset and likely exceed program cost over a 10 years' time. And then for a paper that was just very recently published by Bruno Ventalou and others at INSERM and UNAIDS on the macroeconomic consequences of renouncing universal access to antiviral treatment for HIV in Africa. It's a micro-simulation model drawing from DHS data in Swaziland, Cameroon, Tanzania, and projecting forward to 2034. It's interesting here because this is considering and focusing on the macroeconomic impact of alternative treatment scale-up scenarios. That is, what is the impact on gross domestic product, gross national income? And looking at one at which it freezes coverage levels, one that provides universal access based on the previous guideline of initiation at CD4 less than 200, and extended universal access at CD4 less than or equal to 350. In all the cases, the dominant strategy was extended universal access, which is also cost-saving in Swaziland and Cameroon for society and dominates other strategies. In Tanzania, it's only partially compensates the increased program cost and nets, but it's still considered highly cost-effective. What's that saying to? What's the difference in Tanzania? It has to do with the GDP per capita in the country compared to the treatment cost, which means that that it's sensitive basically to increases in GDP. It's also sensitive to decreases in the cost of providing treatment. Again, which is, I think I can keep coming back to, is our challenge as program implementers to keep finding ways to deliver the services more cheaply, and by so doing to increase the cost effectiveness of those programs. So strategics and potential epidemic impact. And just to talk quickly here, there was a request early on with the convening of the Scientific Advisory Board to look at understand the potential epidemic impact and resource implications of accelerated treatment scale-up, reflecting the 052 findings, but with the specific question, not simply to replicate the modeling that's already been done or done by others, but to understand what can be done in light of the realism about the global health resource constraints and understand what would be required to allow accelerated scale-up. We actually drew on the expertise of John Stover on this and the AIDS impact model as the basis for estimating on the epidemic side of accelerated scale-up, and drew on the cost parameters drawn by the PEPFAR ART cost model and brought these together. So the idea is to understand if you could gain additional efficiencies, further drive down the unit cost of providing treatment, how much more treatment could you buy, and what could you gain from buying that treatment in terms of epidemic impact? So somewhat different question I think some of the modelers have had here. So, and in this case, it was prior to specific recommendations, but looking at who are those patients most easily accessed and where. And so in terms of bringing down the cost of treatment, looking towards standardized package of care and treatment, increased task shifting, decentralization, community models, and further streamlining of commodity procurement and management. So for the Kenya example, in working with our Kenya colleagues, we looked to see what could be realistically expected over 5 years' time in terms of treatment cost. And it was thought approximately 25% decrease compared to current would be possible, compared to a base case of maintaining the 2011 coverage with no efficiency gains. So the question, this is a what-if scenario. If you're able to buy more efficiency, what can you buy with it? The priority groups that were identified for acceleration, we're focusing on those groups that were already in the system. So in this case, patients with CD4 below 500 who are already in care, lifelong ART, option B plus, pregnant women, scaling up according to guidelines for patients with active TB, and persons known to be in serodiscordant couples. This would add about 323,000 patients to the treatment roles in Kenya. We chose Kenya precisely because the other elements of effective combination prevention, male circumcision, and PMT-CT rates were already relatively good in that setting. So we were trying to look at what would be the incremental impact of scaled up treatment. So what this is showing is the red line is showing basically what maintaining coverage rates means you keep maintaining increases in your program scale with no change in unit costs, then that marches up going forward. If you're able to invest more heavily up front and at the same time focus on bringing down unit costs, there's a possibility of actually stabilizing treatment cost and increasing coverage. And again, thanks to John Stover's work in modeling here, and could then significantly drive down incident infections over that time. So that the conclusions here that accelerated scale-up could reduce incident infections by 31% over 5 years and would avert about 93 infections for every 1,000 patient years of treatment provided. Again, not intended to be the final word, but I understand sort of how we're trying to focus this on what the trade-offs are in terms of what could be realized. Where can we find further efficiencies? One of the things we've also seen out of treatment studies, both our own and others, is there continues to be significant heterogeneity across sites in terms of the unit cost of treatment. I should point out, too, that there is also substantial and significant heterogeneity in unit cost across all program areas. And that this drive for efficiencies is not only about treatment, it's about focusing on all our programs to reap more program out of the existing dollars. The other piece, finally, to put on the table, because I think it's going to keep coming up in terms of access here, is that work done by Andres Baruti and others in Tanzania and Kenya, looking at the patient cost, the direct cost to patients for accessing treatment. In Tanzania, nearly $35 per patient per year, much higher in rural areas and urban areas, as you might expect. Kenya, nearly $52 per patient per year. So I think what this points to is some of those things that are actually good for the patient in terms of finding ways to community programs, community pickup and the like that will actually reduce the burden on patients for accessing and adhering to their treatment may also be good to the system in terms of lightening the burden on the health systems, the real resources. This is an issue not only about financial resources, but also the real resources of healthcare workers, health infrastructure, laboratory infrastructure, to the extent we can make those go farther. And just some acknowledgements and thank you.